Hi everyone, this is Maunank. We're still waiting on a couple of discussants, but who else is on the line with us right now?
Hi, this is California Department of Health TB Control Branch.
Great, welcome. Well, maybe what we'll do is we'll go ahead and, in the interest of time, start presenting the case, and then anybody that wants to chime in can do so, and I think we'll have a couple more people joining us shortly. Over here, we have some other faculty in the room as well. Dr. Lippincott is here as well. So I'm just going to go ahead and start on this case. So this is a 58-year-old HIV negative. Hi, Ravandi.
Yes, I'm sorry for the delay.
No worries. So we were just about to start the presentation. So this is a case of a 58-year-old HIV negative traveler from the Philippines who'd arrived to the U.S. about 3 weeks prior to the initial presentation. He had traveled to 2 other cities before coming to Baltimore. He had a known history of TB that was treated with 4 drugs in the Philippines in 2010, so he'd had some experience with the symptomatology. He had noted that he'd had a couple of weeks of a productive cough. He'd had an intentional 10-pound weight loss, but then in this context he started noticing some blood-tinged sputum, which prompted a hospital visit, where he was found to be febrile, otherwise doing okay. He had a past medical history of diabetes. This was not a diagnostic dilemma, so this was on admission. His chest x-ray revealed infiltrates, and as you can see, he had fairly significant right upper lobe infiltrates with cavitation that was fairly extensive. Despite all of this, he actually looked and has continued to look relatively well. He is oxygenating well. His vitals are otherwise stable. And his initial sputum, he was put into respiratory isolation, and his initial sputum was sent off for TB evaluation and was heavily smear positive, which reflects to a gene expert, which was positive for MTB and showed an RPOB mutation. I'll just reveal that his cultures do eventually grow about 14 days into this hospitalization. But just to kind of keep this chronologic and to walk through the case and the decision making, at this point we knew he had within a day or so that he had an RPOB mutation. It was TB. The MTBDDR, which is the CDC's rapid molecular resistance of molecular detection of drug resistance service, had been requested but was not yet back. And I wanted to just kind of walk through the initial decision making and ask about what other people might be thinking. I will say that given his initial relative stability, there was a number of people that advocated potentially for waiting on initiating sort of a full MDR regimen. But I thought this was, well, maybe I'll stop there, and I've kind of already sort of let the cat out of the bag. But I think one of the things that certainly influenced our decision making were the public health considerations, which sort of, in the fact that he's a traveler, has no other home to go to, and that he's going to likely be in respiratory isolation, which it prompted us to want to start therapy sooner than later. But I wanted to just pause there and just get a sense of how often are people choosing an empiric MDR regimen versus trying to wait on additional drug resistance information, and whether these public health considerations really impact your decision making at all. Anybody out there want to weigh in on that? So maybe this is not such a controversial sort of topic. I think, you know, I'll just kind of say that part of what we are trying to balance is the knowledge that this is a person that has been on first-line drugs before. We don't entirely know what his extended drug resistance panel is going to look like, and the fact that choosing an empiric regimen may or may not be so straightforward. With sort of weighed against both the hospital utilization standpoint, which is not heavy on my consideration list in most cases, but recognizing that this person may be in for a long hospitalization, at least thought about that fact that getting him to smear and culture negative sooner than later would be in his best interest, and thinking about the fact that his travel has obviously been truncated dramatically, and thinking about his own from the patient perspective, trying to avoid being in isolation for a prolonged period of time. So those things kind of weighed into our decision making, and we decided that we were going to go ahead and start him on something. And so I guess before I kind of go to the next slide, I'll just ask I'll start there and ask how would you construct an empiric MDR regimen in this context, knowing that he's been on likely RHZE in the past? Maybe Ruvandi, do you want to chime in there, and others are welcome to kind of chime in as well.
Yeah, I think ideally in this patient who has high risk for drug resistance, you would want to know that you would want to have their MDR results. And I think often you can get these back fairly quickly, within 48 hours. But I think because of the public health concern, I think he's also had a pretty extensive burden of disease. I think I would construct an empiric regimen. So I would probably use something like, I would probably use a 6-drug regimen with PZA and ethambutol, but with the presumption that it will not be effective, and then use fluoroquinolones, probably moxifloxacin, and we tend to use amikacin as aminoglycoside. And then I'd probably choose linezolid, and then some drug between cycloserine and ethionamide. Probably actually PAS, because I think ethionamide I would wait to get the INHA testing, so I'd probably do cycloserine or PAS as the 6th drug. Great.
So Ruvandi, you had a little bit of an echo there, so it came through a little bit choppy. I don't know if that's happening on my end as well, but just to recap what Ruvandi said, she mentioned including PZA and ethambutol in the regimen as first-line drugs that may be active, and then amikacin as the aminoglycoside that is often used in our U.S. context, followed by a fluoroquinolone being moxifloxacin, and then at least 2 other drugs. And she mentioned cycloserine, ethionamide, and PS as the ones to be that are often considered, recognizing that ethionamide may have cross-resistance with INH, and then linezolid as well. And I'll say that that's kind of how we approach this patient also, in that we try to include first-line drugs. This is sort of taken from the Curry Center's guide, which I think is really nicely written and very clear. I recommend for those that haven't looked at this before. And I think it kind of spells out the way the systematic approach to constructing an MDR-TB regimen. I think the caveats, as Ruvandi was mentioning, is that we don't necessarily know whether there's going to be PZA or ethambutol resistance, and so for that reason, thinking ahead of time about maybe adding additional drugs with the assumption that one or more of those may be resistant. And hoping to have at least 4 active drugs into this regimen. And so to do so, you may end up using PZA, ethambutol, the fluoroquinolone, aminoglycoside, plus 2 or 3 of those additional oral second-line agents. I circle linezolid only to highlight for everyone that this is sort of moved up from what used to be quote-unquote like third-line drugs and has sort of moved up into the oral second-line drug sort of category. And I think most people are in fact making heavy use of linezolid as a very good drug against tuberculosis. So I think we've covered sort of these particular topics. The other drugs that I just wanted to highlight, and you'll see why in a moment when I talk about this patient, is the third-line drugs, and to think about them, and I'd be curious to know whether anybody else is using any of these third-line drugs, particularly carbapenems, right up front as part of inpatient empiric management. And whether or not anyone would replace one of the oral second-line agents with carbapenems. I'll tell you sort of what we did in a moment, but I'm just curious, maybe those in California or some of the other health departments that have joined, in the inpatient context, just given the ease of dosing and some of the additive GI toxicity of some of the second-line drugs and things, would anybody use carbapenems or any other third-line drugs, clofazimine if it was available easily, in lieu of any of the currently recommended oral second-line agents? Anybody want to be brave and chime in? Ravandi, what do you think? Have you guys on the inpatient side ever been substituting?
No, we haven't had to because we actually have fairly good access to be able to cycloserine, ethionamide, and PAS for the last MDR patient that we have. We don't see so many MDR patients and in the inpatient setting, so we haven't. But now I think increasing data on the carbapenems, maybe we would in the future. And we certainly are using more nasal as I think other people are too.
Yeah, I don't know if is Texas on the line by chance? Be curious to hear if you guys are using any additional carbapenems or other third-line agents as we gain more evidence, particularly on carbapenems and clofazimine, and given that they generally are pretty well tolerated. But so I'll just say, and this may be a little bit of our bias here, just because we've been studying carbapenems for a while in our TB center and feel like there's increasing evidence on their activity against tuberculosis. I think there's a lot of questions that are still outstanding. Certainly, it would not be. I don't think there's sufficient evidence to sort of move it up in the guidelines at this point, but partially for ease of dosing and access, we have tended to use this regimen that I've listed above on this slide as one of the empiric regimens that we go to not infrequently in these scenarios where we're including some oral agents if we can, the PZA ethambutol, then often, particularly if they're extremely ill and unable to tolerate oral regimens, this tends to be our IV go-to regimen of amikacin, moxilonazolid, and miro plus augmentin to give you the clavulanic acid. In this person's case, we did not need IV therapy, so we were giving these medications, the moxi and linazolid, orally. But some of this is just a practical consideration, which is that our inpatient pharmacy does not necessarily keep these drugs in stock at all times, and so we did not have cycloserine, ethionamide, and PAS immediately available, and that's part of why we have ended up using meropenem and clavulanic acid more frequently right up front. But because of where the evidence is at and sort of the weight of experience, once we had cycloserine and ethionamide and other drugs available, we did tend to incorporate those into the regimen in lieu of the meropenem. In this case, I think the decisions were largely made for us. So to kind of walk you through this gentleman's course, he did turn out to have uncontrolled diabetes. He had been on oral agents as an outpatient in the Philippines. Here he was initiated on Lantus and short-acting insulin for sugar control. But within just a few days, his kidney function, his creatinine rose fairly dramatically. His amikation troughs were undetectable, and this was after only a handful of doses of an aminoglycoside. And so I think the question I wanted to pose to the group, and this is not a surprising event that happens, usually further out in people's treatment course, but I'm wondering how you would adjust the regimen on this basis, and if you had the oral agents now available, what might you move to next?
This is California.
Yeah.
I was going to add in from what we're using Augmentin, I think, more, but usually when we use it, it's more towards the end of therapy when we have people we just are really trying to get through, and they've had a lot of side effects. We have not used it early like this. We do use a lot more like cycloserine at the beginning, and we've recently been doing some more early like bedaquiline and trying some other things, but typically we're not using Augmentin until later. I think in this case, one thing we've tried to do initially, if we really want to keep the injectable on, is we'll try 3 times weekly. And sometimes, I don't remember the age of this guy, but in our patients we're usually only using 10 mg per kg. So sometimes we try spacing it out to see if it's more tolerable before jumping to something else.
Great, thanks for that. And just to clarify, this person, the Augmentin in his case is not as a standalone drug. It was only to provide the clavulanic acid, because clavulanic acid is not available in the U.S. by itself, so you have to sort of give it co-formulated with Augmentin. But it's meant to be there to provide the clavulanic acid to help reduce the MICs against carbapenems, and that's so that was the only reason we included Augmentin as well. But really, the agent we're using in this case was the meropenem. It's interesting to hear about going early to bedaquiline. I think we'll kind of come back to that as well in this case. For this patient, we were very nervous about continuing the aminoglycoside, but also the carbapenem here, because there was some concern that what we were really seeing with renal's input was interstitial nephritis attributable to beta-lactams and not necessarily aminoglycoside therapy right up front. So we were actually keen to discontinue both of those drugs, or as you mentioned, space out the amikacin or try an alternative strategy. We were quite nervous that this person actually has a fair bit of underlying diabetic nephropathy, so we were not entirely sure how far we were going to be able to get with the aminoglycoside anyways. But I think we had some similar thoughts. We had additional information that came in essentially on the same day or the day after, which also pushed our hand a bit. So I should have circled the things that are relevant here. But so he did have an RPOB mutation, so suggesting rifampin resistance. He had a CAPG mutation, which confers high-level INH resistance. Just to say that probably because he did not have an INH-A, his ethionamide was likely sensitive. He did, in fact, have mutations suggesting resistance to ethambutol and PZA, so he essentially has resistance to all first-line agents. He did not have a gyre mutation suggesting quinolone resistance, but he did have this RRS mutation, which suggests amikacin and kanamycin resistance as well. They sort of note possible capreomycin resistance, and the report says that 45% of the isolates with this mutation have caprio resistance in the CDC's hands, but others have found this percentage to be higher. We conferred with a number of other individuals and investigators and sort of looked into the literature surrounding this mutation, and I think the consensus was that it was unlikely that capreomycin was going to end up being sensitive, or if sensitive, the MICs were going to be fairly high, and that I think in many people's hands they have found high rates of cross-resistance to caprio and streptomycin, and that's been shown in the literature as well. So I think what we have here is all first-line drugs that are high-level resistance and very likely or certainly have injectable resistance as well, so a pre-XDR case. I think on balance, we sort of decided that eliminated the aminoglycosides from this person's armamentarium moving forward. So with that, I don't know if Ravandi, do you want to take a stab at how would you construct your next regimen with this resistance pattern?
Yes, I agree. I also wouldn't use caprimycin in this patient either. I think in this patient, I would be inclined to think about using bedaquiline because I think based on the CDC guidelines, I think he meets the criteria for thinking. I think it's for patients who otherwise can't construct an optimal regimen. And I think that you could argue that this patient falls into that category. And so I think I would look into getting bedaquiline access for this person. And I think, so at the moment, I think he's on moxilinasolid. I think he's on moxilinasolid, and then the meropenem has also been stopped. Is that right?
That's right.
Yes.
Hey, Maunank, this is Wendy Cronin.
Yes.
It's hard to understand your guest speaker, so if you could just repeat what she's saying after she says it, that would be really helpful.
Sure.
Her voice is picking up a lot. Thanks.
Yes.
Yeah.
I'll be very sorry. It's so echoey. I would look into bedaquiline, and I would probably also use clofazimine because we have an institutional IND for that, and then add that to moxilinasolid, and then probably some combination of PEAS and cycloserine or ethionamide.
Great. So I can summarize what Ravandi was saying. Looking at it, so maybe just to recap a little bit, just kind of thinking, using a little bit of hindsight to think about what our initial regimen was. So I kind of came back a little bit. So if you notice on this regimen, even we had made the decision to move forward with an empirically initiate, but this sort of speaks to why it's really helpful to get the MDDR results early. This person, of the drugs that we had chosen, had resistance to the PZA, ethambutol, and the amikacin, and was really on just moxi, miro, and linezolid. So still 2 and maybe 3 pretty solid drugs, but still did not end up having as many drugs as in the active regimen right up front as we would have perhaps liked. Ravandi was saying that she would choose based on this. So we know moxi is active. We know the linezolid is likely to be active. The miro is out because of this consideration of interstitial nephritis. So we have moxi, linezolid, and then she recommended starting bedaquiline, and then adding on. So you'd have bedaquiline, moxi, linezolid, and then adding on 2 or 3 of the remaining drugs, selecting from cycloserine, ethionamide, PAS, and she included clofazimine in that list. And maybe I'll push you a little bit on that, Ravandi, and maybe others can chime in here too. I've been sort of quite fascinated and interested in trying to understand where people are ranking and rating clofazimine and bedaquiline in these regimens. So we've lost amikacin as well as the other second lines, but are there people, and so maybe I'll do this stepwise. So my first question is there anyone in the audience that would think that bedaquiline is not indicated in this patient? I'm hearing silence, or maybe I should pose it the other way and force people to speak up. Can I get some others on the line to also maybe chime in on what their regimen would be and to specifically comment on whether you would use bedaquiline up front, plus or minus, and would you consider clofazimine in lieu of bedaquiline, or how would you make that decision? Maybe California, you were mentioning you guys are using more and more bedaquiline. Maybe you could comment on how you're adding the third line, quote unquote, drugs into this regimen and bedacoline's particular place in the regimen.
I should say we've used it a couple times. It's not something we're using all the time, but I think that we would consider using, the moxilinasolid. We'd probably add ethionamide and cycloserine. And I think we would try bedaquiline. I think the reason we've been liking it early in some cases is it seems to do a really good job. at really decreasing the burden of disease. And it sounds like this guy, that's one of his major problems. The only trouble, and we've only had, again, a handful of patients on it, but the only trouble we've run into is QT prolongation on the patients who are on, in particular, we had one patient on clofazimine, bedaquiline, and Moxie. And that patient had to have the bedaquiline intermittently stopped because of QT prolongation. So certainly that would be a consideration before we started it. But assuming it's normal, I think we would consider using it in this case.
Great. And would you favor bedaquiline over clofazimine in this person, or consider both?
I think we would consider both. Usually we can get bedaquiline faster than we can get the clofazimine. So I think we would probably, talk to the patient and the team about side effects, but I think we would kind of lean towards the bedaquiline.
Great. So I'll say that we had a similar thought process, and I think we conferred with a number of people as well and felt like bedaquiline was the way to go. I'm smiling because you said that you can get it fast. I think that is not the experience we have necessarily had, and mostly related to the cost involved and trying to figure out who and where the bedaquiline was going to come from. This is a patient that is a traveler who does not have insurance, and so the social workers, just to kind of walk people through sort of what has happened, worked hard along with case managers to try to identify funding sources for the bedaquiline. He did not qualify, I guess, for emergency Medicaid, or perhaps that couldn't be instituted rapidly, and did not have drug coverage for the bedaquiline. So we've had to go explore alternatives, and to make a long story short, we have been able to obtain the bedaquiline to be initiated. The clofazimine is a similarly long story to initiate, because we do have a multi-person IRB-approved protocol at Hopkins and in the state, but we haven't yet gone down that route because it's not obviously straightforward to obtain quickly, and there's the issues of additive QT prolongation. I think this audience knows very well a lot about bedaquiline, so I won't go into all the details, but just for those that might be watching that are less familiar, it's a novel agent of a different class. It's an ATP synthase inhibitor. It has good sterilizing activity comparable to rifampin in mice, but also seems to have good early bactericidal activity, as was mentioned, to try to reduce bacillary load. There have been a couple of studies, and just to say that in the phase 2 trial, there was a marked reduction in culture positivity by 56 days in MDR-TB patients that were given bedaquiline compared to placebo. And just to kind of highlight this a little bit more, the median time to sputum culture conversion was reduced by almost 40 days. I'll say that's probably a key point in us being able to convince people to pay for this drug, given that he remains in respiratory isolation in the hospital at the hospital's cost at this point. And I think folks on this line know that there has been this concern around the QT prolongation and this quote-unquote mortality imbalance that was observed at the end of this study, in which individuals in the bedaquiline arm had a higher rate of mortality, but it was not clear that they were linked to the actual bedaquiline usage. This drug was approved back in 2012. It's given for a 24-week period, starting at 400 milligrams for 2 weeks daily, then 200 milligrams 3 times a week. It does happen to cost quite a bit, but the provisional guidance is that it should be used when an effective treatment regimen cannot otherwise be provided. And I would say that this person meets that criteria, and in that he doesn't have an injectable on board, and so he's sort of outside the standard MDR TB purview. I thought it was just worth highlighting. I will admit I have not gone through this document and things in a tremendous detail. Sorry, this is the older WHO guidance, but what I was going to say is that there's been this new updated review that has been just recently put out in the last couple of weeks from the WHO, which summarizes the evidence since they put forth their interim guidance back in 2013. This is largely cohort data. I put the link there for others, and others can kind of parse through this document as well. But I thought it was interesting because I think one of the concerns has been around the QT prolongation that was just mentioned, but the anecdotal experience, I think, particularly in those that have used it for NTMs as well as we have, has been that we have not seen as much QT prolongation as I think we had expected. The drug's actually been quite well tolerated. This is again, there's not a comparator arm necessarily, but this was a meta-analysis that the WHO sort of undertook, reviewing about 500 plus cases of MDR patients that have been treated with bedaquiline, and essentially you can see this is actually, I should have labeled this better, I apologize, this is the culture conversion, I believe, and you can see that it all sort of hovers at around 80%, which was considered to be good and above what one would have expected in most of these cases in using our standard sort of approaches. This is a busy slide, and again, I sort of just came across this data just recently, sort of provided through an email blast from DRTV Stat Bulletin. And so I'm taking some of this from that, from their report, but I think the key points that I wanted to just highlight was that, so 80% was culture conversion when you looked at the outcome as they defined it in terms of treatment success. It was around 70% for those that had bedaquiline included. Interestingly, there was about the rates of QT prolongation were relatively low. It was less than 5%, and they had no cases of fatal cardiac arrhythmias. I think that was worth noting. Most of the common side effects, I'm just sort of summarizing from this document, it's got a lot more information than this, was GI and metabolic. I didn't really see a breakdown of what the quote-unquote nervous system side effects were, but that was noted to be among the more common. But that the guideline group essentially judged, and this is sort of the quote, that the effect of bedaquiline on culture conversion essentially was large enough to outweigh the harms in most patients. Again, there are limitations. These are cohort studies, but I thought on balance was quite timely to see this information, which all sort of supported, I think, the inclusion of bedaquiline in this patient's care. I think we've chatted about this a bit, but I think that the access has remained, has been as much of a reason we have used it so little in the U.S. As other reasons. I think the cost is quite prohibitive in many instances. It's around $30,000, I believe, for public health pricing, and you have to buy the whole course up front. You can buy shorter amounts and sort of evaluate treatment response and tolerability, but then you get private sector pricing, which I believe is quite a bit more. This question has come up a couple times for us in the last couple weeks, and I'm just wondering whether, and I think people have said this, but maybe Ruvandi and the folks in California can comment on this. Would you see any reasons, just from cost and things aside, to choose clofazimine over bedaquiline? You know, the way the guidelines are sort of... no, I think you were okay now.
Sorry, what were you saying about the guidelines?
Well, just that, the way the guidance is written, they sort of both are sort of lumped together as group 3 or third line drugs, and I think it makes it a little bit less clear how one chooses one over the other. I'll tell you my take and sort of the take of some others that we chatted with, but would like to hear others' input here too.
Yeah, I don't think I would choose it over bedaquiline, aside from maybe from a toxicity standpoint. But I think if you couldn't get bedaquiline because of cost issues or because you had, I think that it's hard to tease out the effects of QT prolongation from each individual drug. But I think for this patient, I'd be more likely to try to use both drugs. And I think if I had to choose one, I would probably choose bedaquiline. But if a patient was having a lot of toxicity related to bedaquiline, I might think about adding clofazimine if I hadn't already done so. Because what we've found in our NTM population is that it's extremely well tolerated, and we really haven't seen the only patients who have had some stable QT prolongations are the ones who have been on other QT prolongation agents as well, such as azithromycin.
Great. So I think there was a little bit of an echo, but I think to paraphrase, that you would choose bedaquiline over clofazimine, and that it's actually been generally quite well tolerated, and you have not seen QT prolongation unless being used with other QT prolonging agents such as erythromycins. Maybe from the folks in California as well, have there been instances in which you would choose clofazimine over bedaquiline other than for side effects, if you had to choose one, or if you were sort of had to make a choice?
Well, I will say that we have had patients that have had private insurance that has covered bedaquiline, so that has made a big difference as well. I think we tend to prefer that, though in some cases, if it seems like getting the clofazimine will be easier, the cost is too much, we'll go with that. But it takes a couple weeks to get it. We have a standing state IRB approval, but sometimes the counties need their own or need to apply for that. Sometimes the patients are a little nervous about kind of signing that huge document. But I think we'd be comfortable using clofazimine, and certainly if it seemed easier, if it seemed like the patient or the treatment team was more, amenable to it, I think we would go with it. If all things were equal, I think we would go with bedaquiline.
Great. And I think, and I'll just sort of summarize, we obviously reached out to a lot of people in this case as well, and I think just from a medical standpoint, so some of the other considerations that haven't been mentioned, all the things you guys have said were what we were thinking as well. Some of the additional considerations was that we actually do have randomized controlled trial evidence surrounding bedaquiline. We don't have that type of level of evidence for clofazimine in TB. That was one consideration. Another is that there seems to be there does appear to be a early bactericidal effect of bedaquiline in helping people get to culture conversion faster, whereas I think people's feeling has been that clofazimine's role in the regimen may be more more in line with treatment shortening of an MDR-TB course overall. Hence, its sort of inclusion sort of based on its inclusion in these WHO quote-unquote short course regimens, and people feeling like clofazimine might be the agent in those regimens that helps for the long-term treatment shortening, but perhaps has less of a impact in this early phase of therapy. And maybe this speaks to what both of you have mentioned, which is the role of both in a regimen, right? These are not mix and match drugs necessarily, and that they may, in fact, similar to our first-line drugs, each have a unique position in the drug regimen overall, and that there may be reasons to include both bedaquiline and clofazimine in providing different types of therapeutic impact. So I think that's very helpful to hear. Part of why I wanted to have this conversation is that is simply that these costs can be quite prohibitive, and so I think it helps to understand and find some consensus around sort of pulling the trigger on spending the money for bedaquiline. But I think what I've heard uniformly is that bedaquiline would be the drug that people would try for if you could get it. I think I'm not going to, I think in the interest of time, I won't go into all the details around clofazimine, but, its role is still sort of being sorted out. But there have been a handful of observational clinical studies in which it was included, including the sort of the short course MDR regimens, the Bangladesh regimen, as it were, and so it seems to be safe and tolerated, and may have particular activity against against non-replicating bacteria, sort of the quote-unquote persisters, to help as a sterilizing agent. I don't know if Ravandi, do you want to sort of talk about this slide about the cross resistance and the uses of calcium channel blockers?
Yeah. One thing I think is worth saying about the use of clofazimine. I saw at the Union conference, Chuck Daly presented really nicely the way a short course regimen actually came about, which was a 12-year process where they evaluated multiple different regimens, where they took out some things, added them back in depending on the results. And one of the things that was really notable was the success rates increased a short course regimen dramatically after they clofazimine. So I thought that was interesting. And the other thing is that as a result of the randomized, one of the, I think, arms of the STREAM trial is designed to actually try to tease out the impact of clofazimine in a shorter regimen. So we may have some good data at some point over the next 12 to 24 months. And so then on to this slide. I think a lot of the concerns about clofazimine and bedaquiline, I think they've been more theoretical concerns rather than what has been seen clinically, especially since we don't have access to clofazimine resistance testing in much of the world where it's being used. But basically, what they found is that for bedaquiline resistance, there's target-based, so related to the ATP synthesis, but it affects. And there's also non-target-based resistance. And the non-target-based resistance is still driven primarily by efflux pumps. And so there's cross-resistance with bedaquiline through this mechanism. And so there's been some work looking at mutations in one of the transcriptional repressors of the genes encoding the specific MMP S5L5 efflux pump. And then with that knowledge about efflux pump-mediated resistance, there's been some interest in looking at calcium channel blockers like verapamil. So there's in vitro data that show that verapamil can decrease the MIC for bedaquiline and clofazimine by as much as 8 to 16-fold. But I think the in vivo mouse model data is less convincing that effect has not been seen.
Wow, yeah. So that was great. For those that the sound didn't come through quite as well, I think some of the key points that Randi sort of mentioned are quite interesting. That the role of clofazimine sort of came about. She was mentioning that in the Union conference, that Dr. Daly gave a presentation, sort of walked through sort of how the regimens have come about, the Bangladesh regimens, and thinking about substituting various drugs, and then clofazimine sort of being the one that seemed to be part of what allowed you to shorten treatment. And that there does appear to be this potential cross-resistance between clofazimine and bedaquiline mediated by efflux pumps. So you can get bedaquiline resistance in a targeted way, but in which the target of bedaquiline is altered, but there's also a more generic drug resistance mechanism related to efflux pumps where the drug is basically pumped out, and that's a similar mechanism for clofazimine. And so there have been some evidence suggesting this cross-resistance, but that cross-resistance or that the MICs might be able to be reduced somewhat if you add efflux pump inhibitors, namely in the form of calcium channel blockers. I think, but as Ruvandi was mentioning, the in vivo data is still, I think there's still work to be done to see this in vivo as well. I'm going to kind of skip ahead so people can kind of wrap up on this case, and then I think Ruvandi has a couple of questions on our case as well. But the phenotypic DST just recently came back, which essentially confirmed all of the molecular test results The additional piece of information we discovered was that the PAS appears to be resistant as well. But essentially, he is resistant to amikacin, streptomycin, INH, resists rifampin, PZA, thiambutal. So this is a pre-XDR strain, but the linazolid LSA appears to be sensitive, and we don't have bedaquiline DST testing available, and the clofazimine DST is still pending. Along the way, so the person, I should just say, I should have recapped, is now on a regimen of bedaquiline, moxifloxacin, linazolid, cycloserine, and ethionamide, I believe. In that setting, unfortunately, the cycloserine levels have come back a little bit on the high side, and the platelets have sort of not declined tremendously and have plateaued, but have sort of stayed at around in the 130s to 150s, and has raised a couple of questions surrounding linazolid dosing. And just wondering about if anybody has thoughts. I think, Caitlin, I don't know if you were just able to join as well. Maybe you want to comment on the linazolid dosing strategies. We typically have used 600 milligrams once a day based on the in vitro and mouse data, as well as what was studied has been studied in the clinical trials. But wondering about whether folks have tried intermittent dosing or lower dosing.
In the past, we did dose-reduce linazolid below 600 milligrams a day for at least one patient who was having severe neuropathy, and I believe, if I recall correctly, that we used 400 milligrams daily, or it might have been 300. It was either 300 or 400, and I think based on some literature that I had seen from work in Korea, where that was used as a dose reduction strategy to try to mitigate neuropathy. But I have not tried intermittent dosing. I was interested to see an email exchange that you had that suggested that might be a better strategy, like taking into consideration the PKP data about this drug.
Yeah, so I'm just going to kind of keep going there. I don't know if, Ravandi, is this do you want to comment on this slide?
Yes, a lot of information. I think we tend to use 600 milligrams. I think probably most people do, but it's interesting that the next TB study, which is ongoing in South Africa, which is a study that's pretty small numbers, but it's shown extremely good outcomes for XDR patients. We're on a regimen of an oral regimen for 6 months of bedaquiline plus ritomanib, and then 600 milligrams BID of linazolid. And so I think they've had, 5 deaths, and the cohort is small. I think it's around 30 to 40 patients. But aside from one patient, they've only had one relapse, but then they have the 6-month endpoints. And so it makes you wonder about whether a higher dosing would sort of help in terms of shorter regimen for cure. And there is a phase 2 study that's actually looking at doses from 300 milligrams up to 1,200 milligrams daily. And then the other thing that we're saying, based on systematic review data, is that there's no evidence that culture conversion or treatment success was different with a lower than 600 milligram dose versus higher than 600 or lower, or 600 or greater than. But the myelosuppression, which is relevant to your patient, was higher, was with the higher dosing. But between the 600 versus higher than 600, neuropathy and other side effects associated with permanent discontinuation weren't different. So
Great.
I think if they're not symptomatic, I might keep them on the. If they're on 600 daily, I would probably keep that and watch platelets.
Yeah, so I think that is what we've tried to maintain them at 600 once a day. I think this is all super fascinating information, and I think as you mentioned, I think there's not necessarily evidence that higher than 600 milligrams impacts culture conversion, but it's interesting around this next TB study, which I wasn't aware of. I think the higher rates of myelosuppression in the neuropathy is what people get into trouble with in terms of tolerability at higher than 600 milligrams once a day. I think the thing about 300 milligrams, that just say that in the randomized trial, in the New England Journal, the Lee et al. Paper, I think in many patients you may be able to get away with the 300 milligram dose, but I believe they did have an increasing rates of resistance, or that they had greater amounts of resistance seen in the arm that dose reduced to 300 milligrams compared to those that weren't. And I think in a person, in the context of this patient who has a heavy bacillary load, I think we're quite worried and nervous about emergence of resistance with dose reduction. We did, as Caitlin sort of alluded to, we've conferred with a number of people who work on the mouse model and do other PK work, and one of the alternative dosing strategies that was mentioned was 600 milligrams thrice weekly as a way to reduce toxicity, and that might have more favorable PK compared to 300 milligrams daily. I can't speak intelligently about why one would choose one versus the other, but I think if we were to dose reduce, that's sort of what we were thinking of doing in order to preserve the higher dose, but just to do it more intermittently.
Could I ask a question?
Yep.
This is Caitlin.
Yep. Go ahead.
I was just wondering whether anybody would try Tadalafil, or whether it has any less effect on the marrow than linezolid.
So we did not explore that, and we can certainly talk to some of our folks that work on these accessibility nodes. But my understanding is that I thought that they are not necessarily more potent, and that the reason you're seeing lower amounts of toxicity is that those are being dosed at a level that would also be expected to have less efficacy. So it's basically sort of, it's not that you're getting an equivalent. So some of those other drugs, you're seeing less myelosuppression and neuropathy, but it's because of the way they're being dosed. And if you wanted to get it to an appropriate dosing that was comparable to the linezolid 600 once a day, that you probably would see the higher rates of myelosuppression. I'm saying that without having looked into it, but that seems to be what I recall. I don't know if there's anybody else on the line that wants to comment on that. Okay. Well, Ruvandi, we have about 5 minutes. Do you want to give us an update on your prior case, or do we want to hold that for next time?
Depends if you think we have. I can do it very briefly, and we can see if people have time to comment.
Sure.
So hopefully people may remember, this is a 20-year-old woman from Cape Verde who basically presented with weight loss malaise in June, and she has a history of SLE, and with mycophenolate mofetil and azathioprine at this time. She was diagnosed with pulmonary mediastinal TB, pulmonary TB and TB lymphadenopathy at the end of July. She had a therapeutic drug monitoring which showed that she had persistently low levels of RIF, INH and diabetes between August and September, at which time it was confirmed that she had a drug-susceptible TB. She had therapeutic levels with dose adjustments by the middle of October, and then was switched to RIF and INH in November of 2016, and has been doing much better clinically, has gained weight and is feeling much improved. And she's now at 8 months of treatment. So what I was wondering if the group could comment on, would there be any reason to extend treatment beyond 9 months for this patient who has been therapeutic at least on the 4 drugs, and then the 2 drugs for just under 6 months? And would repeat imaging help you to make this decision?
Yeah, so just to recap, and just to walk through this in a couple of quick questions, Ravandi. So this is, just to recap, 20-year-old with pulmonary and mediastinal TB, diagnosed and started on therapy in July and August, but it sounds like the majority of intensive phase was at subtherapeutic drug levels, and really, so but it got adjusted. But just so I've got the timing correct, did she after she became therapeutic and had the adjustment, did she complete a full sort of intensive phase after that point? It doesn't. It sounds like it was sort of right in the middle. So she got probably half of her intensive phase at a subtherapeutic level, a half at a therapeutic level, and then the continuation phase essentially has been okay. So I'm just trying to think about the timeline. So in terms of the phases and things, November is when she began her right. So was her intensive phase essentially extended?
It was extended because she was subtherapeutic, and then so I think she's actually one of she's not being deployed in my clinic, but I think what happened is that she had a month to a month and a half of therapeutic levels for the intensive phase, and was then switched continuation phase. So she didn't get the full 2 months of therapeutic levels on intensive therapy.
And has she done? And she's doing well clinically now. So I think I'd be happy to hear what others in California and other places think. I think this is a question that is coming up frequently now. Is that what do we do when we get subtherapeutic levels in the middle of a phase, basically? And I don't think there's any data to guide us in terms of thinking about, do we restart that phase and sort of redefine it? I think this has come up on some prior cases where others suggested they are not taking that route, that they are not starting sort of the dose count all over, but rather they are tacking on therapy at the end. I think there's not probably a right answer, and my gestalt is really to think about it just in terms of, are you achieving some of the other goals of care at the various time points, thinking about particularly around the time when you're sort of ending intensive phase, have you culture converted appropriately? Have they started gaining weight? And then, I think whether or not to extend is difficult when you don't sort of discover the subtherapeutic levels until sort of midway. My gestalt in this person, just so I've got it clear, is that it's really, I kind of think another way to think about this person is that they had 1.5 months of therapeutic intensive phase, and now at this moment would be at 4 months of a continuation phase. So they're really only at essentially the 6-month mark if you think of it in that context. And then it's sort of a matter of how much quote-unquote credit do you want to give them for the, and so maybe I'll stop there and say if that was the situation, and they culture converted in a timely fashion things, I think you could say there was not necessarily indications for a treatment extension if you completed 6 months of appropriate therapy based on the case as you presented it, right? If she wasn't cavitary, this is just she didn't have prolonged time to culture conversion potentially. So you could think of it in that context and say, she's gotten 6 months of quote-unquote adequate therapy, which should be enough because it was really a little bit of an abbreviated intensive phase. From the time she was quote-unquote therapeutic, I think I might be looking to add on at least that much of time to get her to 6 months of at least therapeutic drugs. And it might be one way to think about it. I think I would not necessarily be going another 3 months further, because it seems like if this was localized pulmonary or mediastinal disease and she had good culture conversion rapidly and bacillary load came down rapidly, I'm not sure that she really meets other criteria for extension, and you've sort of already extended her. You sort of just extended her up front in my mind. But I'm not sure of what the right answer is. I could probably be convinced in a different direction. I don't know if Caitlin or others want to. Chris is going to chime in here too.
When did the patient culture convert?
Within a month. She actually had just a few pulmonary nodules, and so I think the bulk of the disease was external lymphadenitis. So she's had negative sputum culture step 1.
Right. It makes it a little bit harder even because you don't have a good way of monitoring microbiologic response.
So I think if she had culture converted in that initial sort of sub-therapeutic time frame, it makes you feel even better about that initial sort of intensive phase that maybe wasn't optimal.
Would anybody use repeat imaging to determine the duration? I find that I think we do it often, and I find it not always very helpful because I tend to find that there's often radiographic persistence, and especially with lymph nodes, they sometimes evolve or even enlarge, and I'm not entirely sure that it correlates microbiologically or with relapse. So I'm not sure I would necessarily use repeat imaging to guide me here. I'd really go more based on whether you thought this was, I think really if you can't follow microbiologic response, my surrogate is just thinking about right up front, what did I think the bacillary load was, and if it was a really high bacillary load in this sort of scenario, and I tend to go for a longer period of time under the assumption that it probably took you a longer period of time to culture convert right up front, and then thinking about needing a longer period of treatment. Now, how much more, I'm not sure. She's had a total of 8 months, so I think maybe I would try to get her to at least the 6 months of therapeutic, so we're basically right at 9 months. And then but I don't know if Caitlin or anybody else has any other last thoughts.
I concur with those thoughts. I definitely have seen lymph nodes wax and wane and seemingly not have much to do with microbiologic response. In fact, I saw a young man who completed TB therapy 3 years ago recently who suddenly had, his lymph nodes pop up, and presumably this is old dead antigen because when we biopsy the node and, we can find PCR evidence of TB, but the cultures are all negative. And it doesn't look like there's active new granulomatous inflammation on pathology either. So I definitely think there seems to be something else going on with lymph nodes, and I agree with the limitations of using imaging for deciding treatment duration. I would go for probably 9 months total, at least 6 months of effective therapy, as you suggest. But we don't count treatment period before we get therapeutic drug levels.
Great. I think we're over time. Thank you, everybody, for joining. We will let you know about the next case, but probably won't happen until May, since next month is the NTCA meeting, which hopefully we'll have nice case discussions down in Atlanta with everybody in person. Thanks.